Picture this. It's 2 a.m., you're on call, and a 76-year-old guy just rolled onto the ward. He's breathless, completely drenched in sweat, and literally cannot lie flat. You check his vitals, and honestly, the numbers are terrifying. Pulse, irregularly irregular at a racing 160 beats per minute. Blood pressure is totally tanking at 90/60. You get an ECG, and it confirms atrial fibrillation. Chest x-ray, acute pulmonary edema. Guys, he is in frank cardiogenic shock. So this brings us to the ultimate chicken or the egg clinical mystery. Did the AFib cause the heart failure, or did the heart failure trigger the AFib? In real-world medicine, this dangerous combo is one of the most common and honestly, one of the most critical scenarios you are ever going to manage. And getting this wrong, it's definitely not just an academic mistake. This specific combination absolutely skyrockets a patient's mortality, their stroke risk, and the likelihood they'll suddenly deteriorate on you. Welcome to this explainer on heart failure and atrial fibrillation. Today, we're playing clinical detective. We're going to solve that 2 a.m. mystery we just talked about, and we're going to build you a totally foolproof survival framework for the wards. Section 1. The vicious cycle. Let's look at the foundational pathophysiology here because it's basically a vicious feedback loop happening right inside the heart. It's a complete two-way street of deterioration. First, how does heart failure actually cause AF? Well, left ventricular dysfunction drives up filling pressures, which literally, physically stretches the left atrium. That stretch causes fibrosis and electrical instability, and boom, you've got AF. But then, AF turns right around and actively worsens the heart failure. So exactly how does AF make heart failure worse? Well, there are four main culprits here. First, you lose the atrial kick. Normally, your atria pump out about 20% of your ventricular filling. When you've got stiff, failing ventricles, losing that 20% makes your cardiac output just plummet. Second, that fast ventricular rate severely shortens diastole, which means less filling time and, crucially, less coronary perfusion. Third, the irregular rhythm makes filling super inefficient. And fourth, if that fast AF persists, it can actually cause something called tachycardia-induced cardiomyopathy. The AF itself is physically damaging the heart muscle.
Section 2. The 5-step framework.
Okay, so how do we actually fix this? We need an actionable, algorithmic game plan. Here's your 5-step clinical reasoning guide. Step 1. Is the patient unstable? Like, are they showing signs of shock, hypotension, or severe pulmonary edema? If yes, you do not pass go. You don't wait around. They need synchronized DC cardioversion immediately. Step 2. Is the AF acute or chronic? Because that dictates if cardioversion is actually safe without anticoagulating them first. Step 3, is this HFrEF or HFpEF? Step 4, are we aiming for rate control or rhythm control? And finally, Step 5, stroke prevention. Because remember, AF combined with heart failure means an incredibly high thromboembolic risk.
Now, I want you to burn the crucial point of Step 3 into your memory forever. In HFrEF, so that's heart failure with a reduced ejection fraction under 40%, you must absolutely avoid non-dihydropyridine calcium channel blockers. I'm talking about verapamil and diltiazem. Why? Because they physically worsen systolic function. Giving these drugs to a patient with a weak, failing ventricle, it's literally like pulling the handbrake on an engine that is already stalling out.
Section 3. Real-life management.
So, how do we tackle Step 4 on the wards? Rate versus rhythm control. The goals here are completely different. If you're going for rate control, your initial target is a resting heart rate under 110 beats per minute, usually using beta blockers, digoxin, or amiodarone. And actually, digoxin is a fantastic tool to remember here, especially for your sedentary or hypotensive patients, because it slows the AV node without tanking the blood pressure. On the flip side, rhythm control is preferred if the AF is actively worsening the heart failure, or in younger patients. We're looking at cardioversion, amiodarone, and catheter ablation. And as we'll see, modern catheter ablation can seriously be a game changer for survival.
To show you just how miraculous restoring rhythm can be, let's look at this case of tachycardia-induced cardiomyopathy. The sources highlight a 55-year-old patient who was stuck in AFib with a heart rate of 140 for months. Their ejection fraction was a dismal 25%. But here is the crazy part. After successful rhythm control, that ejection fraction bounced all the way back up to 55%. The fast heart rate was literally the sole cause of the cardiomyopathy. Catch it, control it, and it's an entirely reversible cause of heart failure.
Section 4. Red flags and mistakes. Let's raise the urgency a bit, because things don't always go perfectly on the ward. Mistake number 1, and yeah, I'm repeating this because it's just that important. Giving verapamil or diltiazem in HFrF will precipitate cardiovascular collapse. Seriously, just don't do it.
Mistake number 2 is over-aggressive beta blockade in acute pulmonary edema. Look, we all know beta blockers are an absolute cornerstone for long-term heart failure survival. But in the acute setting, when a patient's lungs are literally filling with fluid and they're teetering on the brink of cardiogenic shock, aggressively pushing beta blockers will crash whatever compensatory mechanisms they have left and make the shock worse. This is an emergency, guys. It's not the time for slow, oral medication titration.
Mistake number 3, treating the rate without hunting for the triggers. You have got to play detective here and ask yourself, why did the AF happen in the first place? If you just blindly slow the heart rate without realizing your patient has underlying sepsis or an active MI or a PE driving that tachycardia, you're going to lose them. Always hunt for the trigger.
Mistake number 4 is a super specific but easily missed rule for stroke prevention. DOACs, so direct oral anticoagulants, are generally our go-to for stroke prevention in AF, right? But if your patient has AF alongside severe mitral stenosis, DOACs are out. They're just not appropriate. In that very specific scenario, the answer is clear. You absolutely have to use warfarin.
Section 5, Survival Summary, and the FAL-MNIC mnemonic.
Let's wrap this up with the ultimate tool to anchor everything we've talked about. Next time you're on that 2 a.m. shift and that sweaty, breathless patient rolls through the doors, just remember why AF in heart failure is so incredibly dangerous. It fails. F stands for fast rate, which shortens filling time. A is for atrial kick completely lost, instantly dropping your output by 20%. I stands for irregular filling, making the heart super inefficient. L is for low output, which leads straight to shock and pulmonary edema. And S stands for stroke risk, which is sky high thanks to the blood stasis in those fibrillating atria. Remember the FAILS mnemonic, and you'll know exactly what you're up against.
I want to leave you with this final, kind of provocative thought. Historically, rate control was just the standard, go-to strategy for chronic AFib and heart failure. But with so much modern evidence showing that early rhythm control, specifically through catheter ablation, can massively improve symptoms, ejection fraction, and actual survival in the right patients, is rate control becoming a thing of the past? The paradigm is definitely shifting. Mastering this balance is what's going to define the best clinical detectives of the future. Thank you so much for joining me for this explainer, and I'll catch you next time.